What is diverticulosis? This is outpouching of the colonic mucosa and the submucosa through weak points in the muscular wall. It's most often in the sigmoid colon, and it is extremely common. Like more than 50% of people older than 60 have it. Usually the patients are asymptomatic, and it's just found incidentally on a colonoscopy or a CT. People think it happens because of chronically increased intraluminal pressure. So if they have low fiber diets, then they have hard stools, and then there's a lot of pressure when they're straining. These outpouchings are not inflamed or bleeding at baseline, but oh my, can they cause problems. But diverticulosis is really like the baseline condition, and complications arise when one of those little pouches bleeds or gets infected. Diverticular bleeding, it's the most common complication. Those little vasorectal arteries running along the diverticulum will over time get thinning in the vessel wall and rupture into the colon, and this leads to acute painless large volume hematochezia. The clues for these patients are gonna have bright red or maroon blood per rectum. It's often sudden, they won't have any pain or fever. If it's severe, they might have hemodynamic instability. How do we manage this? You wanna get IV access to large bore IVs, resuscitate as needed, give blood as needed, but nearly 80% of these will stop spontaneously. If it's ongoing, these patients may benefit from a colonoscopy, a little epinephrine injection there, clipping or cauterization, and then they may also benefit from IR embolization if endoscopy fails. And then surgery could be considered like a segmental colectomy if it's a life-threatening bleed, recurrent or uncontrolled. Diverticulitis is inflammation and infection, so the diverticula becomes obstructed by stool. The bacteria kind of overgrows there, then you have some microperforation leading to the inflammation and the infection. These patients will have pain. It's usually going to be left lower quadrant abdominal pain. They might have fever, leukocytosis, they may have nausea, vomiting, or even urinary symptoms, and they may be tender in that area. Sometimes you might even have a palpable mass there. These patients can have a lot of different complications. So you can get an abscess, a fistula, they might have a perforation leading to peritonitis, or strictures leading to bowel obstructions. A contrasted CT abdomen pelvis is the gold standard. You want to look for peripolic fast stranding, bowel wall thickening. Also look for an abscess or a perf, right? How do we treat this? So we're aiming antibiotics towards gram-negative rods like E. coli and anaerobes like Bacteroides fragilis. If it's uncomplicated diverticulitis, you can send them home with PO antibiotics like Augmentin or Cipro and Flagyl. They need bowel rest and close outpatient follow-up. Complicated diverticulitis gets admitted to the hospital and they get IV antibiotics. We usually do ceftriaxone with Flagyl or even Zosyn, make them NPO. They might need drainage or surgery. Abscess formation is one of these complications, so this would be localized to the pocket of pus adjacent to the inflamed diverticulum. These patients might have persistent fever, leukocytosis, or pain despite 2 to 3 days of antibiotics. And on CT, you'll see a pericolic fluid collection with rim enhancement. How do we manage these patients? If it's a collection less than 3 centimeters, you can continue the IV antibiotics and closely monitor these patients. Greater than 3, think about a CT-guided percutaneous drainage. And then anything that's refractory or recurrent, think about a surgical resection. You can also get fistula formation. So chronic inflammation causes abnormal tracts between the colon and the adjacent organs. Most commonly, it'll be the colovesical fistula. And again, these patients may have pneumaturia, fecal uria, or recurrent UTIs. You can also get a colovaginal fistula, and this would be passage of stool or gas through the vagina. And then you might have colocutaneous or colocolonic fistulas. These are more rare. How do we manage these patients? Definitively, they'll need elective surgical resection of the disease segment and repair of the fistula. You want to be treating these infections like the UTIs or whatever it is supportively before they go to surgery. Let those organs heal up a little bit. Something else they might get, perforations and peritonitis. So the diverticulum can rupture, leading to free air, free fluid, and diffuse peritonitis. These patients will have sudden, severe abdominal pain. They'll have a rigid abdomen, peritoneal signs, and free air under the diaphragm. These patients unfortunately need an emergent exploratory